Hello friends, today we are going to discuss about cognitive behavioral therapy for body dysmorphic disorder. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about body dysmorphic disorder, that is BDD. What are the steps, process involved in doing CBT for BDD patients? CBT was founded by a psychiatrist named Dr. Aaron T. Beck. He is considered as the father of cognitive behavioral therapy. Now let's understand about BDD. BDD is characterized by a distressing or an impairing preoccupation with slight or imagined or perceived flaw or defects in one's physical appearance. The wording is very clear. It is perceived flaw. There may be minor impairment, but the distress associated with the patient is huge. BDD is commonly conceived to be a OC spectrum disorder based on similarities with OCD, such as preoccupation with imagined defect or a perceived defect or even a minor defect, that is obsession, compulsion of checking, mirror checking, camouflaging, rituals, reassurance seeking, avoidance, and various other activities. Invariably, it is considered to be the brother of OCD. However, in a general population, majority of us will have insecurities with regard to their appearance. Then how it is different from BDD? It is different qualitatively and quantitatively. What is qualitatively and how quantitatively? Quantitatively, the BDD preoccupies 24 hours. Every minute, every second, they are worried about their appearance. This leads to avoidance, impairment in their biological, occupational, and social function. However, the insecurities with regard to their appearance may be self-conscious. They do come in daily. It may be hardly maybe 15 minutes, 20 minutes, or 30 minutes, commonly in adolescent, and afterwards they are able to overgrow this. Invariably, many of them say, I don't like about my nose, but I'm fine the way I am. So the insecurities are there, but they do not come in their way of functioning. So how does BDD differs from general population insecurities? In BDD, the current research says that the patients become preoccupied with the minute details of the face or the perceived body which is ugly. That means they get into minute details to that level, they are unable to come out of it. They are unable to see the whole body as a person rather than the face or the perceived body is being defect. So that's the difference, and that leads to poor quality and quantity of life, my dear friends. So this is how you need to understand the difference between quantity and quality with regard to insecurity and BDD. The whole thing revolves around whether it impairs their academic, job, social activity, and family activity. If you look at this BDD, they are recurrent thoughts, preoccupation, excessively concerned about their perceived flaw or minor defects which there in their face or in the body parts. It preoccupies more than 3 to 8 hours, my dear friends. The commonest being skin, nose, hair, eyes, teeth, jaws, lips, facial features, breast, genitalia, muscle, thighs, buttocks, and so forth. The commonest is the skin, the wrinkle, acne, scar, vascular marking, pallor, darkness, disfiguration. Facial features like asymmetry, forehead, chin, nose, prominence of the cheeks, lips, eyes. With regard to genitalia, it may be breast, penis size, and so forth. So here in BDD, the 24 hours is not enough for them to think about their perceived flaw. Invariably, they end up in checking mirror, repeated grooming, applying excessive cosmetics for camouflaging, repeatedly touching, constantly asking for reassurance, skin picking, and also asking for surgeries. Many a time, they avoid this perceived flaw by wearing big glasses, scarf, covering with hands, hats, nowadays with masks. Many a time, they avoid looking into the eyes of the other. They would like to sit in the corner of a room and go away without socializing anybody because they are afraid that somebody will detect their flaw and make comment about that. Many a time they do demand for repeated consultation with cosmetic surgery, and also even if the surgery is done, they are not happy with the surgery. Invariably, they become litigious against the surgeons. Very, very small amount, maybe around 5 to 10%, may benefit with surgery, but remaining 90%, invariably, they are not happy with the surgery or the BDD continues. Invariably, they end up avoidance, avoiding public situation. They drop out of school. They drop out of academics. They are unable to focus on the job. They lose their job and they become conscious in social situations. They avoid social situations. They do not go to birthday parties. They do not celebrate their own birthdays. And also, this lead to severe occupational dysfunction. If the marriage is there, the divorce will occur. And if they are unmarried, they will not go into date. And invariably, this leads to poor quality of life, my dear friends. And many a time, they are unable to maintain relationship with others. And if you look at the BDD, the current diagnostic criteria, they talk about 4 specifiers. With muscle dysmorphophobia, that means the young male adults who are concerned about their muscle mass, that like they want six packs, they go on doing the gym and they are excessively concerned about their body image. Many a time it is good insight or poor insight, and with absent insight leading to delusional belief of body dysmorphic disorder. So invariably there are various core specifiers. The more the severe is the poorer insight, it is difficult to do CBT. At the same time, maybe even the outcome may be slightly guarded, but however, the medication and CBT is required for poor insight patients. Invariably, the onset is the adolescent, 18 years. Men and women are equally affected, and invariably 10 to 15 years is the treatment gap. That means they are suffering from BDD, they do not seek treatment, they end up going to various ENT surgeon, cosmetic surgeon, asking for surgery. Invariably BDD is a chronic disorder and it is invariably recurrent and invariably fluctuating. And in BDD, the depression, suicidal attempt, and completed suicide is very common, and the quality of life is very bad, my dear friends. Invariably, they do not stick on to therapy, and invariably, the therapist should be aware of BDD, how the patient reacts, how chronic is this illness, and how many years and the long term CBT is required. That means the patient may require more than 25 sessions. In many a time, depending upon the comorbidity, the sessions may require maybe 1 year or 2 year. But invariably, with the adequate right treatment, many of the BDD do get better over a period of time. If you look at the explanation of BDD, why this BDD occurs, if you look at that, in the you can see the two circles. One is the external circle, that is blue, that is external factors outside the patient. The other one is internal factors within the patient. Whenever there is a past history of teasing, bullying, abuse in the childhood, that means there has been abuse with regard to these young kids, and this abuse may be with regard to their looks or maybe regarding their the way they walk. So invariably this lead to triggering, and then they start focusing on that part of the body. That means there is a selective attention to that part of the body, and they start processing whether my face is right or not. They start comparing with other, they start comparing their skin with the other models, other people, and invariably they have a high aesthetic sensitivity. That means they become perfectionistic with regard to The looks, the symmetry, the skin has to be this kind of color, and that perfectionism becomes the enemy to the patient. And over a period of time, negative appraisal, if there is any criticism or if they are unable to bear the stress and somebody makes a comment about them, it may not be regarding their looks. They believe that they rejected them because they are not good looking. This leads to rumination, and rumination leads to depression, anxiety, and further, has anxiety levels picks up, safety behaviors picks up, they do not go outside, and that further causes more BDD. Invariably, if you look at that, they become hyper focus on their minor details of the facial expression, skin, bone, symmetry, perfectionism. That hyper focus on minor details is the biggest problem in BDD, my dear friends. But however, once they develop this BDD, they develop also coping mechanism in terms of safety and avoidance behavior. In turn, this maintains their symptoms for chronicity. Mirror checking, repeated checking whether they have the perceived defect is improving or it is decreasing or it is becoming more. They start camouflaging, that means applying more makeup, maybe clothing, hair, masks, goggles, reassurance seeking from the family members, and they start comparing with others, maybe models, maybe their own old photographs, comparing with the social media, excessive grooming rituals they have to do in a specific way, specific skincare has to be done, monitoring others' reaction when they go out, they will look at the other people, how their facial expression is there. By chance, somebody makes some kind of grin, they believe that they did looking at their flaws. That means they start misinterpreting, and they also start looking for medical surgical solution. They go to the skin specialist, they ask for cosmetic surgeon, they ask for even surgery, avoidance of social situation, they do not go into public places, they do not go to school dropout, college dropout, job, they do not hold on to the job, marriage will break. And invariably, sometimes patients become so afraid they stop even seeing mirror, or else some of the patient becomes overusing of the mirrors. So these are the various safety and avoidance behaviors are seen. Now comes, what are the challenges for CBT? Commonest is comorbidity. Invariably, BDD are known to have 70 to 80% have depression, substance use, alcohol use, cosmetic overuse, deliberate self-harm, suicidal attempt, and OCD. So this will come in the way of doing CBT. So what to do? Invariably, see which is the major problem. If the depression is severe, then you need to focus on depression. If the patient has substance use is the major problem, first focus on the substance use, then move to BDD. But invariably, you need to treat both independently, and also if required, if one of the therapist is looking after depression, the other may start looking after BDD. But invariably, you need to treat both. That is the comorbid condition and also BDD. Many a time, some patients have delusional kind of BDD. That means it is a false fixed belief. In such a scenario, it becomes very difficult. You may have to give medication and then CBT. Many of the patient wants surgery, cosmetic surgery. It becomes very difficult at that time. They will become violent at home. The family will give into the surgery. Many of them may be homebound, refusing to come out of the house. In such a scenario, you may have to consider online CBT. As I mentioned, some of the family becomes accommodative about their demands, and then invariably the family starts giving into the patient psychopathology, or else some of the family members may become aggressive, critical, and high expressed emotion also plays a role in BDD. Further, poor motivation for CBT is also a biggest challenge. In such a scenario, you may have to consider motivational interviewing, and I have done a separate video with regard to this. Now let's move into the actual part, cognitive behavioral therapy for body dysmorphic disorder. It is a structured CBT. Invariably, 16 to 20 session is the idealistic, but it does not stop at 20 session, because in a real life scenario, the patient comes in a chronic condition with comorbidity requiring more than 25 to 30 session, my dear friends. each less sessions lasting for 45 to 60 minutes, one session per week. And invariably, you need to discuss with the family members and the patient. CBT is a training program, and here the patient undergoes training for 45 to 60 minutes and does practice at home. That is the remaining time, 23 days, and remaining 6 days, and in a week, 6 days and 23 hours they need to do practice. Now let's move into the intake session. In an intake session, it is a structured contact between the patient and the therapist. Intake session is focused on the assessment, engagement, and also collaborative planning about how to go about therapy. Invariably, many of the patients are forced to come to CBT. In this scenario, the family will be begging you to do CBT for the patient or do counseling. In such a scenario, it becomes very difficult, but you have to be very, very cautious and also at the same time empathetic towards the patient and the patient's family. Invariably, in the intake session, you need to be very, very cautious and try to develop a therapeutic alliance, understand the current problem of the client, and set initial treatment goals. Briefly ask about their problems, discuss about the expectation from therapy. Invariably, the patient, majority of them, they come that I want surgery, but the family said that let's go to therapy first and then surgery later. So in such a scenario, you may have a window of opportunity to do CBT, and you need to discuss about the role of therapist, role of patient in the training of CBT, and invariably involve family member in CBT. Especially in India and Southeast Asia, having a family member as a co-therapist who will be observing the patient, and you need to prepare the co-therapist. During the session, they need not talk and they do not do any inquiry. Invariably, they need to speak only when the therapist asks. And this co-therapist will play a crucial role in the remaining 6 days and 23 hours for homework assignment. Discuss about the session duration and frequency, take the contact details, consent, payment mode, brief introduction about CBT model, CBT therapy, homework assignment, and if by chance either the therapist is unable to do therapy or if the patient is unable to come, how to contact and how to cancel the appointment needs to be discussed. Moving to the detailed assessment. This is very essential, my dear friends. During this detailed assessment, you need to develop a therapeutic alliance with the patient. So, do a detailed psychiatric assessment. I have done a separate video with regard to the detailed evaluation, collect information from all possible sources, chief complaints, duration of onset, and also history of presenting illness, any past history of treatment, what are the predisposing factor, precipitating factor. Invariably, there will be bullying, teasing in the childhood. What are the perpetuating factors and protective factors? Family history, if it is any mental illnesses there, past history, personal history, and premorbid personality to be looked at. Focus more on BDD symptoms, explore what kind of ugliness they talk about, which body part, look for comorbidity, look for any triggers which provokes anxiety, which provokes sadness, frustration, what are the safety behaviors, what are the camouflaging behavior, and what are the avoidance. Please take 1 day routine activity from the waking up to the sleep. How much time they have spent inside the room, outside the room. It should be a routine day. Like what time they do get up, how much time they spent in mirror, how much time they spent on online looking for the surgery regarding their perceived flaw, and how much they are anxious, irritable. So 1 day routine will give you a full picture how much is the disability. That means whether the ADL requires help or even the ADL, that is activities of daily living, has gone for toss. Diagnosis, look for comorbidity, MSC, cognitive function, and look for insight. If it is a good insight, the CBT will work very well. If the insight is very poor, still there is a window of opportunity to do therapy, but you may have to do motivational interviewing. I have done a separate video on motivational interview. Please go to my channel and look into that. Further, you need to, as I mentioned, you ask the patient to discuss about the perceived flaw or the defect what they observe. Do not challenge here. You are doing exploration. Be empathetic. Accept that they are going through difficult time. Don't accept they are ugly, but you say, yes, I can understand you are going through a difficult time. I I understand that you feel that you are ugly, and discuss about the specific area of the body which is ugly, why, what. Is it the shape, or is it the color, is it the texture? Ask the patient to draw about themselves. By looking at the drawing, you will be able to understand how ugliness, their imagined defect is there. And hierarchy of avoidance also has to be possibly done, discussing with the patient. Now, once it is done, if the patient tells that I want to go for cosmetic surgery, then you have come up with this plan A and plan B. Plan A is patient's plan, that is proceed with surgery. Patient wants to go for surgery and to get rid of this distress. That is the plan A, the patient's plan. Plan B is postpone the surgery for next 3 to 6 months, engage in CBT. That means if there is a perceived flaw or the body image disturbance is there, this can be taken care. And then no need to do any surgery. Surgery is a permanent process. It may go wrong and there are side effects. Whereas CBT has a minimal side effects and perceived flaw can be treated. So here we are not denying the surgery, but at the same time, don't go telling that I will make sure your father and mother will give money to the surgery. Don't get involved in that. But we say you can decide about your plan A. Let's do therapy first. Do not promise that I'm going to engage in surgery with your family members. Don't do that. But you say plan A is your plan, plan B is CBT. So you are getting a window of opportunity to do therapy without promising that I'm going to help them in surgery. This method interrupts the impulsively getting for surgery, which is emotionally driven decision. Invariably, they end up in a very bad way. And even if the surgery is done, they are not happy. They want to undergo surgery again. And by doing surgery, this allows their belief system to become stronger, and it becomes very difficult to do therapy later. And also, by doing CBT initially, the experiential learning will help them, and maybe combining motivational interviewing and medication may help the patient. So, many patients who have undergone CBT invariably have rejected the surgery. So, if the patient has undergone surgery, it becomes very difficult to do therapy now, because invariably the patient is already has the defective part, and after surgery they becomes more worsened and they start hating the doctors or the surgeons who have done the surgery. Moving to the third step, goal setting. You need to discuss about what is the goal in their life, what do they want to become, what is the importance they give for this goal. Like suppose a patient says that I want to become a pilot or maybe an actor. How much is it very important, and within how many years they want to reach there. Next one is goal in therapy. You need to discuss long-term goal and short-term goal. Short-term goal will be about CBT, and also you need to discuss about the important topic which I'll be discussing, what is appearance versus the body image which is formed in the brain. How to change that. From general goal, you need to go to a specific goal which is measurable and actionable goal. Hence, goal setting becomes very essential. You'll be discussing about how to achieve their goal. That goal is he wants to become an actor, or he wants to become a pilot, or he wants to become a doctor or engineer or a AI specialist or a therapist or a gym trainer. So the focus is very clear. It should be very specific. That is the reason it is called as a smart goal setting, which is specific, which is measurable, attainable, relevant, and time based. At the same time, you also start educating about BDD. Do not attack the patient telling that you have BDD. You say, I've seen many patients similar to you. They have BDD, that is body dysmorphic disorder. They have body image disturbance rather than the appearance itself. So let's see whether the CBT helps in changing the body image disturbance. When you are doing education, involve the family members. This will help in decreasing the accommodation and also decreasing the aggression. That is, accommodation and aggression needs to be addressed in BDD. Discuss about the signs, symptoms, give some brochure, materials, diary, so that they understand what is BDD. And also give the clear concept of CBT, that is cognitions, behavior, emotions, and physical symptoms. You may have to do motivational interviewing if the patient is not ready for CBT, and also discuss about what are the maintaining factors, safety, behavior, and avoidance. Here, you also need to introduce something called as body image versus physical appearance. Body image means it describes your perception of your own physical appearance in your mind. That is, including what is their expectation, what is the stereotype is, how they perceive themselves. So that is, here the patient invariably generally for the public at large, they say, yes, he is good looking. But there are minor defects. The patient focuses more on the defect rather than the whole. That means attention to details becomes more important than the whole person has the issue. So here the physical appearance may not change by CBT, but the body image, how they perceive themselves can be changed. So you need to bring this concept. Beauty is in the eye of the beholder or not. What does it mean? Here, the person may look good or may not look good. The person who loves them may believe that they are beautiful from inside, from outside, or both. So you can see a given example of distorted lens. Distorted lens, a same person, when the camera takes the photograph with the different lenses, the same person's image gets distorted. Similarly, in the brain, when the person is normal, the brain may perceive, when they go through their eyes lenses, when the image falls on their retina, this body image disturbance perception may occur, my dear friends. So you can see here the same person with various lenses, the image perception changes. Sometimes the nose may be ugly, sometimes the uh, lips may be ugly. So, invariably, how we perceive the facial features, some people may find some people are ugly and some people are beautiful. So it's basically the beauty lies in the eyes of the beholder rather than the person himself. Once you have introduced this concept, start working towards the CAB. That is cognition, affect, autonomy, basically the physical sensation and behavior. They are all interrelated. Let's look into the cognition. Cognition means the thinking process will affect your emotions. The emotions also will affect your cognition and the physical symptoms. Because of your affect or emotions, your behavior also gets affected. They're all interrelated. What are the cognitions in BDD? Especially in BDD, the patient feels that I look ugly because of this facial feature. I am defective. I am damaged. Other will notice my flaw. They will reject me, and that means my life is gone. People are going to judge me based upon your looks. They are Many patients start. They are looking at me. Whenever I go outside, people laugh at me. People just stare at me. My worth depends upon my look. If I am not good looking, that means I do not have any worth in this life. I should kill myself. If they notice my flaw, that means I will be rejected and I'll be humiliated. And they will say that this flaw ruined my entire appearance and entire my life. I must look perfect. If I am not perfect, that means I should not go outside. Feeling ugly means I am ugly and I am stupid and I am rejected. Only cosmetic surgery can solve this problem. These are the thinking process the patient with BDD will have. What are the emotions? Depression, anxiety, frustration, sadness, irritability, mixed anxiety, depression, feeling of dread, panic attacks. So these are the emotions they have. Physical symptoms invariably palpitation, blushing, trembling, headache, body ache. Those various kind of breathing difficulties, nausea will be there as a physical symptoms. What about the behavior? Safety behaviors are very common. Avoidance is written in BDD. uh, Surgeon shopping, online searching for the literature uh, for various types of surgery, who is the best surgeon, and fidgety, deliberate self harm, reassurance seeking. So these are the various, invariably, the CABS model. That means thinking process affects the emotion, and for emotion affects the behavior, behavior affects the physical symptoms. They are all interrelated, and now we need to break this cycle. Either we can do intervention at the cognition about the thoughts, or at the behavior level, or at the physical symptom level, or at the emotion level. So that means we need to analyze the person. How to do the analysis? Ask them to keep a BDD diary. This diary will start about the triggers as soon as they get up in the morning. When did they get the thought? And what made them to trigger? The trigger is regarding what? Like people laughing at me may be the trigger. He heard some people laughing outside the house. They have not seen them, but still he felt that people are laughing. He believes that my nose is ugly. People will eject. That is the thought. And safety behavior, covering nose with mask, not going outside. What is the rate? The rate is -10, my dear friends. So this kind of charting has to be done. Teach the patient how to do the BDD charting on daily basis, every hour, whenever he gets this thought. If you are able to do over a period of 1 month, you will be able to get a clear understanding about the patient perceived flaw, the thoughts, what are the triggers, what are the safety behaviors, and what are the awareness the patient is doing, and how severe is his feelings. By knowing this, you can enter into CBT, my dear friends. So start with the behavioral exposure. Before you do behavioral exposure, you need to explain the rationale for exposure. That means repeated exposure leads to fatigue of the response. That means habituation. Invariably, the patients who are anxious to go outside, they feel that they will be rejected, they will have sadness. By exposing them to certain situation, these anxiety provoking or emotional provoking symptoms get habituated over a period of time. And further, this reduces the reassurance and avoidance and checking. So, for example, you can see here there is an anxiety with regard to appearance, and that causes invariably, suddenly, whenever he has a anxiety regarding about the perceived flaw, he will have avoidance or a safety behavior. This gives a temporary relief, but there is no habituation. So you need to tell them to stop doing avoidance, to stop having safety behaviors. By doing this, habituation will occur. This lead to improvement, my dear friends. So you have to clearly write them and give no surgeon shopping, no doctor shopping, no mirror checking, no camouflaging, makeup, wearing cups, caps, mask, big goggles, no seeking reassurance, no comparison, no internet checking. They need to tolerate this bodily sensation or anxiety. As I mentioned earlier, invariably BDD patient also will have certain minor sensation on their face or on their skin. They believe that this is becoming worse every minute. So that kind of sensation will provoke their anxiety. So invariably, by avoiding the safety behavior and they are exposing themselves, the exposure, as soon as the exposure done, the intensity of anxiety will be severe, that I'll be rejected, I'll be humiliated, people will just throw me out, so my life is going to end. So this kind of thought will come, and if they stay with this anxiety slowly over a period of time, maybe 2 to 3 hours, this anxiety will come down. Second exposure, third exposure, fourth, fifth, slowly the emotions will come down. That means fatigue occurs regarding these emotions and thoughts. That means no longer that thought will provoke any kind of emotions. Further, you can start doing imagined exposure or in vitro exposure. Here, you will ask him to write a script, or else imagine that he is going in a social situation, and or he's walking near the house or in a busy street, what the people are looking, how they are judging him, why they are judging him. And here you need to make sure that there is no any kind of safety behavior or avoidance, and you will provoke the anxiety, ask him to be with the anxiety so that the habituation occurs. This is in vitro. Or else you can also do exposure in vivo, that means in real life. Make the hierarchy of anxiety provoking situations. It may be mild, moderate, severe, and profound anxiety. Mild anxiety may be standing in front of the mirror for 5 minutes. After 5 minutes, he has to get out of that. And then there will be anxiety, and he will start, I need to go back and check. I need to do camouflaging. I have to do makeup more time. So, by doing this, not spending very specific time only, the anxiety picks up, uncertainty picks up, and he does not go to the mirror, or else delay in mirror checking afterwards, and being at home without camouflaging, going to the neighborhood without camouflaging, or else delaying looking into the mirror after waking up. These are, by doing this over a period of 2 to 3 weeks, you will be able to overcome mild anxiety with regard to perceived flaw and not doing any safety behavior. Then move to the moderate anxiety, going to the nearest shop, spending 10 minutes without doing any camouflaging or checking in the mirror, attending a brief video call with the friends or with other social situations, taking a single photograph and uploading on the social media, and staying with the anxiety. And now moving to the severe anxiety, talking to someone with a closed conversational distance and see what is their reaction, and if they have certain perceived rejection, why it happened, how it happened. And being with that anxiety and uncertainty is very essential. Walking in a well lit public places, not wearing any kind of camouflaging, and being photographed in a group and not deleting that photograph in the social media, and also moving to the high anxiety situation. So slowly you start increasing the exposure and habituation to occur. This is a very important exercise to decrease their emotions, making them more functional and accepting that the people do not reject them. At the same time, you may also do challenging, that is, attention and perceptual retraining is a very essential. Here, these methods retrain the brain to shift from obsessive, detail oriented viewing, which I mentioned earlier. Focused attention will be there, minute perceived details they will be focusing. Now, you need to retrain the brain to look holistically. Here, you need to do mirror retraining, reduced mirror rechecking, and non judgmental observation about their own body or the face, which aims to lessen their emotional distress and improve the body image. This is what we call it as mirror training in a behavioral therapy. In this, my dear friends, you can see the photograph here. A person who has BDD will focus more on the forehead and the hair loss. My forehead looks very ugly and people will reject me. This is how the attention is given to the detail. But now you have to ask them to look at the whole photograph. Here, if you look at the whole photograph, the person is giving the lecture. So instead of focusing on the minor details, looking at the holistic is very essential. So this is the example you can give and ask them to do mirror retraining technique. In this, you need to give a clear cut guidelines. It should be non-evaluation, holistic mirror exposure. It should be very 5 minutes, very time limited, and slowly you can increase. It will increase their perceptual broadening exercise by attention, from refocusing from the attention to minor details to the whole experience and appearance. Here, from the minute detail of the nose, skin to the whole face, whole body weaving is the exercise. So, rules of mirror retraining here is: describe yourself without any judgment. Look at yourself as the whole, not as a very part. Small single detail should not be there. Do not use any adjective such as good skin, good, bad skin, ugly nose, big nose, small nose, abnormal nose. I am a monster nose. That kind of adjective should not be used. Stay with the image even if the discomfort occurs. Many a time the patient moves from the whole picture to the minor detail. That is a habit. You need to come back telling that that is a BDD thought. Here, you need to start saying that I see a person. When he goes and stands in front of the mirror, he will keep the alarm and then he will say, for 5 minutes, I will watch myself as a whole. And he will start describing that I see a person standing in front of the mirror. This person has one head, two legs, two hands, two eyes, a nose, a mouth. The person has 10 fingers, 10 toes, and functionality of each body. He has eyes. These eyes can see. He can go outside, look the whole world. He has nose. This nose is functional. This nose can smell the good things. He has a tongue, hands, like this. You start describing the whole person without giving any adjectives. By chance, if they drift to the minor details, that is a habit. Gently, he needs to come back telling that I am having a BDD thoughts. Name the BDD thoughts and leave it aside. The whole purpose is to retrain from moving from minor detail to the holistic approach. If the discomfort rises, stay with that. That is, habituation and extension is the important. In future session, you can change the mirror, change the lighting, change the distance, and also no grooming, no checking, no camouflaging, no reassurance. So neutral description should be there. This is how the mirror retraining is done. If they do over a period of 2 to 3 months, my dear friends, and if there is no any criticality over a period of time, the person's perceived flaws start decreasing. Invariably, the emotions associated with it, deliberate self-harm associated with that, depression associated with BDD will come down. Many a time, the patient will have lighting and distance manipulation experiment also can be done. Invariably, the patient will have a core belief. This flaw, what I have on my nose, is visible to everyone. What I see in the mirror is accurate, and everybody will look into this. And he will say that everyone can observe easily. It is very striking. My flaw, even a small child knows. My flaws are obvious. People can see my flaws from miles. This is one of my patients said that even if you're coming from maybe 1 mile, they can see my flaws. This is how he explained his ugliness to me. So now you have to give the information. You see, light manipulating experiment. If well lit is there, how much it is shown, and if the light decreases, and in the evening if it occurs. That is the reason patient is using in the dark, they will go outside when nobody is observing. So lighting manipulation experiment means they believe that everybody can see under whatever circumstances. Then you have to say, please understand the lighting also makes a difference about the perceived flaw or the defect. At the same time, you also have to talk about the distance. If you look at from the distance, you will not be able to observe anything. If he comes closer, you will be able to see the whole person. Further closer and further closer. So to see the perceived flaw on the nose, they have to be at least maybe less than 1 feet. So by teaching this lighting and distance manipulation, you are asking the patient to go outside without camouflaging or cosmetic, uh, putting more cosmetic. So by this lighting and distance manipulation experiments, patient will start becoming more functional, more social, and this will act as a behavioral experiments. Further, whenever the patient's anxiety becomes more, whenever the patient has severe irritability, frustration, you may start asking for grounding technique or attentional retraining technique can be done. That means when they go outside, they will be focusing more on the other people's reaction on their looks. Invariably, if the person is walking, imagine if a person has BDD and is walking outside and one of his friend is on the phone, the patient will believe that he's doing deliberately not talking to him because he's ugly. So this is their interpretation. So you have to shift the focus from self to others. How to do that? When he goes outside, he will start looking at the 5 objects in the locality, name them silently in the mind, 5 sounds what he is hearing, 5 colors what he can see in and around in the environment, 5 touch you can touch that, name 2 function of the 3 object he has seen around, name 3 person what they are doing. That means you are retraining the brain from shifting focus from self to others and functionality. That means the world does not run around their looks. And by doing this attentional retraining, slowly the patient starts decreasing their belief on their perceived flaw. Many a time the patient becomes extremely upset or maybe anxiety is severe. You may have to consider JPMR or yoga or maybe meditation or anxiety reducing technique. But invariably, many of the researchers say that by using anxiety reducing techniques, habituation may not occur. But it has to be weighed with regard to pros and cons, whether if the person has severe avoidance, then JPMR is very good. So that by teaching anxiety reducing techniques, you can make at least to move him outside. So you need to balance the need for therapy versus avoiding relaxation. If the patient is avoiding therapy, then the relaxation may be considered. Now moving to the uh, identifying the dysfunctional cognition. This you have to go back to their CBT diary, that is basically BDD diary, look at their thoughts. What is their recurrent pattern? What is their thinking process? Invariably, they will have magnification or catastrophizing. Their minor or imagined flaws are looked as very serious. It is monstrous, everybody will know. That is catastrophizing. Selective attention, or focusing on the disliked part more. They'll be focusing more on the nose or more on the jaw rather than the whole face. Mind reading. They start believing that people are noticing at me, the people are rejecting me, people are judging me, people made their faces by looking at me. So this mind reading, many a time overestimation of visibility, believing that the perceived defect is obvious and immediately noticeable to others from miles, what my patient said. All or none thinking, or else perfectionism. I have to be 100% good looking, otherwise I will be rejected and I should not go outside. Overgeneralization. Even if one flaw means I'll be rejected, that means my identity is gone. I'm not a good person. I'll be uh, labeled as a bad, ugly person. Catastrophic prediction. They will be rejected. I'll be humiliated. I'll be a failure in life. Personalization. Interpreting neutral behaviors of the others people as a rejection. Unrealistic appearance standard. That is perfectionism. That I have to have this skin tone, comparing with the model or other people. Intolerance for uncertainty. Inability to tolerate that I have a perceived defect or I have a defect. That means everybody will reject me. Here, who is this everybody? We do not know. They will say everyone in their locality, everyone. That means it is the whole world reject them. Or else, what is that uncertainty? Is the question we need to ask. And then we need to ask whether they are able to tolerate that. Thought, action, fusion. Believing that thinking one looks defective means that is true. If he believes that he is, maybe I'm looking ugly, equal to I'm ugly. So that thought action fusion need to be challenged, and comparative bias, comparing with the models they will have. Now looking into the schemas. Defective schema, shame schema, unrelating perfectionism schema, approval seeking schema, social rejection schema. And these are the various schemas you can see. Further, vulnerability in the social norm schema, visibility and scrutiny schema, identifying, appearance fusion, control, fixing, and emotional intolerance. These are the various schema you can see. At the same time, they will have automatic negative thoughts. And if somebody does not talk to them, if they feel that I'm ugly, hence they are rejecting me. Something is wrong, so I look bad. I look bad means they are rejecting me. My face is ugly, so everybody is uh, making face, and they are rejecting me, or they are avoiding to talking to me. Everyone can see my flaw. People are staring at me. People do not have any other activity, they stare at me. They are judging me, they are judging my appearance, they are judging my functionality. My flaws ruin my life. I look worse in front of people. I cannot be seen like this. I need to hide. I need to fix this. If they notice me, I'll be rejected. That means my life will end. I look disgusting. I cannot cope unless the surgery is done. Only the cosmetic surgery will fix. These kind of automatic negative thoughts will come repeatedly, and you need to teach them how to handle them. And you need to challenge them. So moving to the eighth one is challenging these dysfunctional cognitions by asking Socratic questioning, asking for evidence for their belief, evidence against their belief, and looking for alternatives. Many a time we may also ask for probability re-estimation of risk. If somebody is ugly, that doesn't mean that they will be rejected. For example, you can ask them, a leader, whether he is accepted or rejected. Is he rejected because of his looks or because of his behavior or his personality? So these kind of estimation of risk has to be done. And invariably, you need to generate alternative perspective. Here, you may also do some activities like defocusing and refocusing. Here, you need to defocus from their minute details and refocus on functionality. That means shifting attention away from mirror, that is from the reflections and photos, focusing on the functionality. That means interrupting the mental scanning towards, or the BDD thoughts, to the functionality. That is reducing spent time in evaluating themselves towards thinking about how to function. So here you need to refocus on physical functioning, that is breathing, walking, eating, running, coordination, sensory function, seeing, healing, touching, those kind of thing. Social functioning, speaking, expressing, connecting with people, occupational functioning, working, learning, academic. So you are defocusing from their thinking about their perceived flaw versus refocusing on functionality. So this is about the defocus and refocus. At the same time, you may have to do a value of person exercise. This is very important. Many a time it works. I have found many patients responding to this. BDD BDD patient has a over evaluation on regarding the appearance. If the person is flawed, that means he will be rejected. Hence, camouflaging, all those things occurs. Now, you need to ask that person, how do you value a person? Ask him to name a teacher he likes most and ask him what are the reasons he likes him most. What are the values? Why does he like him? Ask him to name a leader. Why do he admires him? Name a sports person. Why do he admires him? Name a singer. Why does he like him? Name an artist or name an author. Why? So the patient will start telling that I like him because of his maybe behavior, because of his ability, because of his functionality, because of his social appeal, being kind to other people. So that means it is not the appearance which matters most. By defocusing on the appearance, you are moving towards as a person as a whole. That means you have to ask them, why did he like them? He did not choose their appearance. And he himself said that he will be rejected. But he did not reject them because they're ugly. He accepted them because of their functionality and how they made to feel him. That means the value of person is not defined by their appearance or social approval. It is basically the inherent worth of that person and the values they choose to live in. So that makes the person value. That means you are now defocusing from the appearance to refocus on the value of life. That is what is the value of life. Now you have to come here. Now you have to ask him, what are the values in the life? What do you want to become? What is the goals? What are the success? What are the hobbies, travel, achievements, overall quality of life? So here he will give value of life based on various things. And you may also ask him how people should remember him during his deathbed, or you can also ask him how people should remember him after death. Do they remember him as an ugly looking fellow or a good person who is helping everyone? So invariably they talk about, I should be a good traveler, I should be a good singer, I should be a good doing good job, earn money, spend time with the family, friends, spend time in growth, do some social services. This is how they give. Now ask the question, how much time he spent on this? Invariably, they will say 25 hours out of 24 hours they spend on BDD and watching mobile. So the value of life has been gone. So here you need to bring back and telling that we will now focus very little time on personal grooming, on camouflaging. It may be around 5 minutes, 10 minutes, depending upon their family members, how much they do. And if they do only for 5 minutes, you say, okay, may I have to take only 5 minutes, remaining 23 hours, 55 minutes will be spent on value of life rather than focusing on the appearance. So invariably the patient will give the time spent on what are the other things, and then you need to refocus on the functionality. Once he starts doing that, behavioral therapy starts moving in, and you have started challenging his dysfunctional belief, so that will lead to improvement. At the same time, you need to do problem solving techniques to be taught. Ask him to focus on certain problems in life. It may be relationship issues, pursued rejection. Then you need to find what are the problem, what are the solutions, and he need to take the solution pros and cons and choose one of the solution and implement. And the solution has to be flexible. By doing problem solving, the patient will become more functional and he will become more risk taking, and invariably he will start earning and the life worth improves and self-esteem improves. Once the patient start improving, start discussing about weaning and relapse prevention. This is very essential because we do not do endless therapy. CBT is more of structured therapy. However, in BDD, you may have to do more sessions, maybe 25, 40 sessions. But weaning and relapse prevention is very essential. The reason is you need to ask them that we want to make them autonomous, independent, empowered, so that they can take care of themselves, and ask them what are the early signs of relapse, teach them what are the early signs of relapse, and what are the gains they have done till now, what they have learned, and how to challenge themselves and expose. And clearly tell that The exposure is one of the best way to challenge their belief. And by doing this weaning, we are improving their self-efficacy and autonomy so that the therapy can be stopped over a period of time and help them to seek help from other family members, friend, and spouse. These are the co-therapists who will help them coming to therapy, doing exposure, at the same time not doing any reassurance. Finally, consolidating the session. Maybe in the last session, you can discuss about reviewing the diary about the BDD, how much improvement was there, how much travel they have done from the day one session to the till date, rehearse the key points, rehearsal the what are their thoughts, what are their dysfunctional thoughts, what are the exposure they have to do, and the booster sessions. And invariably teach them problem solving and asking for help from other people. And finally, the booster sessions, it may be 3 months once or 6 months once. Look for any comorbidity, look for any resurface of new illness, look for any drug abuse, substance use. And if there is any relapse, ask them to come back, choose a other mode of therapy, motivate in the regular engagement in exposure and coping strategies, support autonomy and relapse prevention, my dear friend. This is what about the BDD CBT, my dear friends. To conclude, BDD is a severe chronic illness with a poor quality of life. CBT is one of the first line of treatment, and it's a time structured psychotherapy, and it will be around 25 to 30 session. Each session lasts for 45 to 60 minutes, ideally 16 to 20 session, but in ideal life or maybe in the real life, you may have to require more sessions. CBT is a training program in which the patient and the therapist spend 1 hour in a week together regarding the session. Remaining 6 days and 23 hours, the patient will implement the homework compliance, and he has to do BDD diary, exposure, tracking the thoughts, tracking the emotion, analyzing the triggers, identifying distortion schemas, and ENT is very essential by doing BDD diary. Start behavioral therapy exposure after explaining the rationale. You may have to do mirror retraining, value of life, value of person exercise, defocus and refocus. Attention and perceptual training are the new techniques which has to be implemented in BDD, my dear friends. Exposure and tolerating the anxiety is very essential in BDD, and invariably the patient who does CBT will improve over a period of time. Invariably, that imagined defect will improve over a period of time, and that leads to improvement in BDD, my dear friends. Thank you very much for giving your valuable time. Stay safe.